everyone. So today what we're going to do is actually see the nursing process in action. We talk about the nursing process a lot in nursing school, and I know that we keep telling you, you need to follow your nursing process, you need to follow your nursing process, but until you actually visualize it, I think it's very difficult to understand what it is. So today I'm going to help you visualize the nursing process, okay? So first of all, I just received report from the night nurse, and the night nurse has given me report on a 79-year-old male named Carl Shapiro. Carl Shapiro has a history of hypertension, high cholesterol. Wife states that he all of a sudden at dinner time started to feel a little weak, and then she noticed that his speech was a little bit slurred, and so she brought him in right away. By the time he got to the emergency room, his left side was completely flaccid, and his speech was very slurred, and according to the nurse, he has a left-sided facial droop. His left side is still flaccid. His right side is still pretty strong, and so he's able to, grab things and use the urinal and use his right side. And so we want to promote that as much as possible. Also on report, I was told that because he came in late last night and now we're starting the shift at 7 this morning, nobody has done a swallow evaluation on him yet. So currently we have him NPO until they do the swallow evaluation. Okay, so now as my nurse is giving me report, I'm already starting to have my wheels spin. My wheels are turning in my head, hopefully, right? Depending on if I have my green tea or not. And so you're thinking, what do I need to go and look for in this patient? What is my patient at risk for? Now, I know when I worked at another facility and I taught clinicals there, we gave the students report on their patient. We would give them the disease process the night before they came to clinical, and they were responsible for going into the textbook and coming up with one nursing diagnosis based on the medical diagnosis, even though they had not seen the patient yet. And the purpose of this is to get you to look into the disease process and already start to think about what is your patient at risk for and what kind of interventions would you want to start doing, right? Well, what is your plan, basically? And then when they came to clinical, that night they would see their patient, they would assess their patient, and then they would develop another nursing diagnosis and plan based on their actual patient. Now that becomes client-centered. As nurses, that's what we do. We don't treat disease processes, we treat the client and their symptoms. So for example, Mr. Shapiro here has had left-sided flaccid, he has this neuromuscular deficit. I've shared with you guys where my dad has suffered 2 strokes, and physically he's in better shape than I am. He can, he runs around with my 6-year-old, he can mow the lawn, he paints my deck, and so physically he's in great shape, although he has suffered 2 strokes. So going forward, now what we're going to do is I'm going to step out of the room and enter the room as if I'm meeting Carl Shapiro for the first time, because I just received report. Now I'm not doing a complete head-to-toe assessment right now for the sake of the video, for the sake of the time, and also because I like to do a rapid assessment most of the time and just come see my patients. But for the sake of the video, I'm going to do a little rapid assessment with focus on which system would I want to focus on. All right, well, if you said neuro, you're correct. Okay, I'm performing my hand hygiene. Hi, my name is Erica, and I'm going to be the nurse taking care of you today. Can you tell me your name and date of birth? Okay, and so obviously I'm checking the ID at this moment and making sure that it matches. But more important, well, not more importantly, but equally as important, because my patient has suffered a neurological, deficit, I'm assessing what Mr. Shapiro was telling me, okay? When I'm asking him, can you tell me your name and date of birth, I'm able to find out a lot of information just by that one simple question, okay? So I'm able to find out, first of all, is he able to answer appropriately? When I walked into the room, was he awake, alert? Did he open his eyes when I came in? Was it when I came and touched him? Okay, based on the way I entered the room, most likely he was already, had spontaneous, what we call it, he opened his eyes spontaneously because I already started to talk to him, okay? And so now I want to see, what is his speech pattern like? So is it slurred, or is there some hesitancy? Is he able to even answer me? Is he garbled? And when I'm looking at him, I'm looking at his facial symmetry to see, is his face symmetrical, or do I see that left-sided facial droop that I was told about on report, okay? And also I'm taking a general survey. Already you might have noticed that his leg is out. He's trying to escape me already, right? But I'm looking at him. His breathing pattern looks normal. He doesn't seem as if he's in any distress. He's about a 30 degrees sitting up, and I'm happy with that based on the fact that he's on aspiration precautions. And so I'm going to say, so Mr. Shapiro, are you trying to run away from me, huh? Is everything okay? I see that your leg is out of the bed. And so he might express to me that he needs to void, or he might express to me that he wants to go to, you know, take a walk, or whatever the case may be. Maybe the patient is confused and he's, you know, trying. So it was a perfect time for me to not only make him more comfortable, but also educate him. So Mr. Shapiro, I know that your wife actually mentioned that you're pretty independent at home, but unfortunately right now your left side is still pretty weak. So for us to get you out of bed is putting you at risk at this time. So what we're going to do is we're going to have physical therapy come and speak with you and work with you. And I'm going to also assess you. I want to see what you are able to do. But right now, if we allow you out of bed, it's not a good idea, okay? And so I can make you more comfortable, and I can help you in anything that you need. But right now, let's try to get you more comfortable into the bed. And so I'm going to put your leg back in the bed, Mr. Shapiro. Or I might even say to Mr. Shapiro, are you able to put your leg back in the bed? His leg was out, but now I want to test and see how strong he is. Now remember, I'm not doing a full neurological assessment right now because for the purpose of the video, I just want to get enough information so we can start to formulate a diagnosis and interventions. But I may want to say, Mr. Shapiro, can you squeeze my hands, and I'm testing his grasp to see how strong he is. Okay, and if he's flaccid on the left side, most likely his grasp is going to be absent. And I'm going to say, are you able to raise your hands and see? And I'm always checking from both sides, okay, to see where he is. Is he weak? Is he strong? What is he able to do? And also I would do the same thing. Now what I noticed about Mr. Shapiro is that he doesn't have any pillows under his sacrum or back to prevent him from developing a pressure ulcer. And he doesn't have any pillows under his legs either. And so that might be something that I can do right now. Okay, Mr. Shapiro, I really want to make you more comfortable in the bed. Did you want to use the urinal before we start? Oh, you just used it? Okay, perfect. And I'll make sure to have it available to you so that if you need it again, you can have it. Okay, so what I'm going to do, Mr. Shapiro, is I'm going to put your head down for a minute. And you always want to put the head down because, you know, you're fighting against gravity. And he's actually pretty heavy. Depending on my patient's level of strength, I may want to ask for some help. Okay, I'm going to elevate the bed. For my back, you want to protect your back. Okay, Mr. Shapiro. So what I'm going to do is, since your left side is flaccid, I want to take some weight off of there. So I'm going to go on the other side, actually. Okay. And so you have a draw sheet here. And, you know, depending on the patient, you might want to put the leg over. This simulator doesn't do that. But you can crisscross the legs, and that's going to help you so that you're having now. You want to be careful because when I turn this patient, remember, he's flaccid. So I want to make sure that I'm keep maintaining skin integrity on this side. And so I'm going to turn him over. And you see now that his sacrum is off of the pillow, and more so his back is there. And I would want to put another pillow under the legs, not under the feet, because the purpose is to keep the heels off of the bed. So I want to put the pillow under the legs, okay? And just because I don't have all my pillows right now, I'm going to reuse this pillow. But in the real world, I would go get another pillow. And I don't want all of his body weight on this right shoulder. So that I could also put this pillow here. Okay. How's that, Mr. Shapiro? Is that okay? Oh, you think that's very comfortable? Okay. Yeah, so this is what I do on a daily basis. I talk to my mannequin over here, and don't tell anyone. He's actually a little handsome once you get used to him. So now I'm going to elevate him, and I want him at least at a 30-degree angle because of the fact that he's at risk for aspiration. And any of these little wrinkles I want to clean. Now he is continent of urine and stool from my report, and also he's told me that he just used the urinal. Had he not used the urinal, I want to encourage him to use it now. It's because a lot of times patients fall because they're trying to go to the bathroom. Okay, and if you notice now, my patient looks really good. He's comfortable. He's in the bed. However, that does not absolve me from him doing this all over again. So part of my plan, I'm going to put the bed down now. Part of my plan is figuring out how am I going to prevent Mr. Shapiro from doing this again, okay, potentially exiting the bed, and maybe next time he'll be more successful and actually get out of the bed. And so what is he at risk for? He's definitely at risk for falls. So what I want to do is have all of the things that he needs readily available to him. So that would include the urinal, because I was told by him and by the nurse that he's able to use the urinal with his right hand. Okay, and I would ask him, Mr. Shapiro, is it better if I put it here for you, or is it better if I put it here? Now, a lot of times the students, when they come in, they want to put the rail up. Just remember, we can't have 4 side rails because that's a restraint, but we can have 3. And so you can have this rail up. We wouldn't really need to have that rail over there because he is he's flaccid on that side. So if he's going to go anywhere, it's going to be over here. The other thing is I want to have everything available to him. Right now, he's actually NPO, so I wouldn't have this because he's definitely at risk for aspirating. So I'm going to put this away. If he was able to eat or drink, then obviously I want to have this available to him. So I'm going to put this away for now. So now my bed is all the way down. I already checked my IV. It's nice and patent. It's not infiltrated. I have 35 normal saline for hydration. Why don't we go ahead and take his vitals really quick, just for the sake of more data. Okay. So I'm taking his blood pressure. I have him on a cardiac monitor. I'm going to put a pulse ox on him. I'm going to check your oxygen. I'm going to take your blood pressure, okay? How are you feeling? How's your breathing? Feels good? Okay, perfect. So he's afebrile with a temperature of 98.6. He's in a nice normal sinus rhythm. Heart rate is 84. His O2 sat is 98% on room air. Like I said, his breathing pattern is beautiful. And his blood pressure is 132/82, which is completely normal in a patient who's just suffered a stroke. Many times when you have a patient who suffered a stroke, their blood pressure tends to be on the higher side. And so we gradually lower it. We don't want to lower it too quickly. Okay, and so that's my assessment. And now what we're going to do is analyze that data and come up with some diagnosis, okay? Perfect. Okay, so now that we've gathered enough data, what we want to start to do is analyze that data and figure out what are all the potential problems or actual problems that we've seen. One book that I really think is great, your school might recommend a certain book, I'm not sure which book we recommend here, but I bought this on Amazon after a student of mine kept giving me amazing concept maps, and I asked her, you know, what is your resource that you're using, and she told me it was this one, and I paid about $11. You might even be able to get it cheaper now because it's been a couple of semesters. And this is the Nursing Care Plan Guidelines for Individualizing Client Care. So you could use this whether or not you're doing concept maps or care plans. It's really great because based on the disease process and what you found, you can go and it'll give you all your rationales. We don't expect you to do this all by yourself in the beginning when you're just learning. You need a good resource, okay? Like I said, my students, that first day, we encourage them to go into the textbook and come up with a nursing diagnosis that from the textbook. so that they can start learning what to look for. And then you're going to go meet your patient and you're going to actually form client-centered concept care plans or concept maps based on your patient. So first thing you want to do is start with your NANDA nursing diagnosis. Okay, so you're going to find, based on this patient, I just told you that his left side is completely flaccid, so he has decreased mobility. He has not eaten yet, so he has impaired nutrition. Because I just caught him trying to get out of bed and he's so flaccid on the left side, he's at risk for falls. And he's also, because of the impaired mobility, he's at risk for pressure ulcers. And I'm not sure if we mentioned it, but because he's not eating, he's also at risk for impaired nutrition. And he's also at risk for aspiration. So there's a ton, but I wrote a couple down here for you. So if you see, the first one is in risk for, now because this is a risk, this is not something that we've actually seen, but we know that based on what's happening with him that he's at risk for it. So risk for impaired swallowing related to neuromuscular impairment. Typically when they have that left-sided facial droop, they're going to have weakness. Okay, and so they're going to have difficulty swallowing. And so what happens is, rather than that food going into the esophagus and into the stomach, it goes into the trachea and into the lungs. And we don't want that, because then they get aspiration pneumonia. Okay, next is impaired physical mobility related to paresthesia, as evidenced by, now I'm not having a risk, now I have an actual problem. Okay, so now I need evidence. Where did I come up with this? Where did I get this from, right? So impaired physical mobility related to paresthesia, as evidenced by left side flaccid. What you want to do, and I probably should have told you this in the beginning, when you're formulating your nursing diagnosis, you want your problem. So your problem or your potential problem related to the cause. So what was it that caused this problem or could cause the potential problem, as evidenced by your signs and symptoms. So what were the signs and symptoms that you saw? What was the objective data that you obtained that led you to believe that this was a problem in the first place? So what we're going to do is start to make a plan and start to perform interventions. Now, I already started to perform some interventions. We're going to take it step by step. So risk for impaired swallowing related to neuromuscular impairment. So because my patient is at risk for impaired swallowing, I want to prevent this patient from, my goal would be to prevent him from aspirating, okay? And so what would I do? My plan will consist of, first of all, in the hospital, it's a little different than the way we ask you to write it on paper. In terms of a nursing process, the plan, they say they want you to come up with short-term and long-term goals for your patient, okay? And so what would that look like? Patient will remain free from aspiration during hospital admission or something like that. What it looks like in the hospital is, now I'm kind of trying to coordinate this. I know that if the doctor has not ordered for the speech pathologist to come and see the patient, I need to contact to get that order, that consultation order. And if it was ordered, I want to make sure that they were contacted. So I might even speak to my secretary, or depending on the facility, we used to do a lot of the calling ourselves. And so I'm going to make sure that they come in and assess this patient. In the meantime, I'm having the patient head of the bed elevated. I'm reminding the patient that they can't eat or drink anything until they have this. And so I want to also provide some moisture to the mouth, maybe with some moisture swabs or some Vaseline. I've just moved on to interventions. But so now my interventions would include keeping the head of the bed elevated, keeping the patient NPO, following up and making sure that the speech pathologist comes in to see this patient. What else would I want to do? Keep the IV hydration going. And so those are some interventions. And then obviously, what does my evaluation consist of? Well, is the patient exhibiting any signs and symptoms of aspiration? So maybe the family member came in and fed them something, or maybe they even can be aspirating on their own saliva. Okay, someone who has severe aspiration, risk for aspiration might even be choking on their saliva. And so I would want to monitor them. For that, I want to be assessing their lungs for any signs of aspiration. Okay, so also my patient, I determined that my patient is at risk for falls due to their impaired mobility. So that's huge. Okay, we talk a lot about safety in the simulation lab, and in the hospital, safety is just, you know, your priority as a nurse. Okay, and so if my patient is at risk for falls, there's a lot of different interventions, you know, that I want to do. First of all, my plan would be, obviously, patient will remain free from fall or injury during my shift or admission. And so what would I do? Well, I did a couple of things already. I lowered the head of the bed. I put the third rail up on that side. I have the patient's belongings. I also would want to get the call bell. You see that call bell all the way over there? That call bell should be here, available to my patient. And I want to orient them to the call bell. Mr. Shapiro, if you need anything at all, you want to ring that call bell, please don't try to get up out of bed. Don't think that you're bothering us, because really we are here to take care of you and want to keep you safe. So I want to orient him to the call bell. If this patient is constantly trying to get out of bed, I want to put a bed alarm under this patient. I would want to maybe even move this patient's room to a room closer to the nurse's station. You know, maybe have a one-to-one. You see, I'm sitting with him. I have had patients that were constantly trying to get out of bed, and I just was so worried about them, and we didn't have the capability of having a one-to-one. And so what I would do is bring my computer into the room and start documenting. And as I'm documenting, I'm still getting my work done, but I'm monitoring my patient. I'm even talking to my patient. I'm letting them talk to me most of the time. I'm just listening so that they have a companion and they don't feel alone. Many times your patient, not so much Carl Shapiro, but your patient who is confused, or just, you know, even a little elderly person who's alone and scared, just sitting with them can make a difference, okay? So I'm performing all types of interventions to prevent them from falling. And so my evaluation would consist of me basically looking back and saying, okay, my patient remained free from falls or injuries during my shift. The next thing is risk for impaired nutrition, less than body requirements related to impaired swallowing. We've already started to perform some interventions based on that. We have the fluids running. We also have notified our speech pathologist, but also I would want to look at Mr. Shapiro. I would want to see his output. Is he urinating? Is he voiding efficiently? Are there any bowel movements? And also, what would be some signs that this pair is having impaired nutrition? Well, with some skin turgor, right? Mucous membranes. And so I would want to continue to evaluate that. And so that's what I would evaluate. Also, weight is a big one. Risk for impaired skin integrity related to decreased mobility. Well, I already started to do some things with that as well. I turned and repositioned my client, and now I know I have 2 hours before I have to do it again. I want to focus on that nutrition, because nutrition is directly related to impaired skin integrity as well. We want our patients to have nice protein and fat and carbs so that they're healthy. What else would I want to do? I would want to notify my staff and make sure that they are coming in and turning and repositioning every 2 hours. And if my patient is incontinent, I want to make sure that they're dry. There are also certain types of beds that you can get. If your patient is really immobile, you want to make sure you can either get a different bed that has that air mattress capability, or they have air mattress overlays where you can put it on top of the regular bed, and those will kind of, they inflate and deflate to prevent pressure ulcers. And so there you have it. That's pretty much my nursing process right there. Okay, so if you guys have any questions, if you want to know anything at all, if there's anything that you want to recommend for me to do, if you have any questions on this and you want to ask me, please leave a comment down below. I'm totally open to feedback. And yeah, I have another video really explaining the nursing process step by step. It's on a PowerPoint, so it's not as, I feel like, engaging and entertaining, but I just wanted to have both of them so you can have both of them to look at. All right, guys. Hope you're having a great week. Bye-bye.